Hey everyone, happy Valentine's Day. We're here to give you pain-free and fully functional volar wrist and forearm and palmar region. And that is the title of the class.
We could say it in English.
We could. How would you say it?
Eliminate repetitive overuse in the forearm and carpal tunnel syndrome today.
Wow.
Incredible?
Yeah. That's amazing.
How are we going to do it?
How are we going to do it?
We're going to do it.
We're going to do it.
Yeah.
Well, before I hand it over to Sharon to tell you more about the class today, just a quick reminder for you guys to tell your friends. You can click the little ellipsis at the bottom there and share this with them. This is a free course on eliminating pain and dysfunction in the areas that we mentioned at the beginning there. And if you're a body worker, you can get 2 free CEUs. You just have to follow us, watch the entire episode, I guess we'll call it, course, and then you have to email us at info@myopain.com with your Periscope handle, your name, your license number, and contact information for us to give you those free CEUs, okay? And are we ready to tell them a little bit about the class today? Okay. Sharon.
Okay, so today, as you know, you probably know, we've cordoned off the body into 60 areas, right?
As you'll know if you've been watching.
That's right.
This is part 41 of the Bodyworkers Mastercourse.
Right, part 41. It's so incredible. We're getting closer to the end, aren't we?
We are.
We're going to be, isn't it amazing?
Yeah.
Okay, so here is the Rosetta Stone of myofascial here that Dr. Simons helped me create. And here today is the areas we're treating is the inside, the forearm right here and the palm area right here. This is so pain in this area, but we're going to also treat the muscles that compress the median nerve. This is the real cause of carpal tunnel syndrome.
Oh, wow. So what Sharon's using here, the pain key chart, you can find that at myopain.com. And the numbers you see before you, 53 and 57, are the numbers of the protocols we'll be using today, which you should and can also download from myopain.com for free. Those are our course materials for today, so you want those.
So what causes volar forearm pain or anterior forearm pain is the most likely one is this first one here, which is the Palmaris longus, then the Pronator teres, which also, interestingly enough, compresses the median nerve, okay? The serratus anterior and the Triceps brachii. Then the wrist pain and palmar pain here on the...
A lot more culprits there.
There's a lot more culprits, and there's some very unusual culprits, okay? So these are, you kind of expect it. The Flexor carpi radialis, the Flexor carpi ulnaris, the Opponens policis right there in the thumb. Now, what you might not expect is the pec major, the pec minor, Latissimus dorsi, Palmaris longus, Pronator teres again, and Serratus anterior. So Serratus anterior.
Some usual suspects and some unusual.
Yes,
suspects.
and this is, you could say, why did we have so much trouble fixing carpal tunnel syndrome? And then why do some people, or a lot of people, after having carpal tunnel surgery, cannot do activities that they were able to do before? Because we never really fixed all the things that need to be fixed. Okay?
Yeah. So there still might be some issues because the issues with all of those areas might
How
not
about the
have been
pec
addressed.
major, the pec minor, the Latissimus dorsi, and the Serratus anterior? Okay, so we're going to take a look at the pain patterns there.
Cool.
Okay.
And another thing, I guess before we jump into it completely, you'll want to get hold of some self-care tools.
Oh, yes.
As we go through the class, we'll be telling you to do a bunch of different things with tools like those. If you have a back knobber, jack knobber, tiger tail, anything like that.
So I like to, I printed this, and then I like it because I can fold it, and I put like my materials in it,
Yeah, your
something like
handy
that,
pain key
So
chart.
just have it real quickly
Take it
available.
anywhere. Yeah.
Yeah.
And that's both sides. Yeah.
Yes.
That's nice.
Okay, so let's take a look at some of these muscles, okay? And we're going to look at the protocols that we're going to use today. Okay, so we're going to take a look at the Palmaris longus. This is the most likely one to cause pain in the anterior forearm. Okay, so here it is, and it causes pain also down into the hand, right there, into the palmar side of the hand. So here, and you know what? Though this is interesting. Look at me for a second. it also helps to pronate. Like, what do we do that's pronating all the time?
Typing.
Typing, because this is supinating. What's the opposite of that?
Pronating.
Pronating. And what's the most likely muscle here that we're going to be treating today to cause carpal tunnel syndrome would be the pronator teres. But in addition to the pronator teres, we also have the numerous other muscles causing pain and dysfunction due to pronation. Okay? So this is one.
Pronation is the big culprit today.
Yes, it is.
Perpetuating factors.
Now
right?
some of the other, yes, it is, yes.
In that position.
Now you can see here the pronator teres. Here's attaching right here.
Pronator.
So these are a lot of these are attaching right here at the common tendon here. So so this would be, so they're all coming up here and attaching here. These ones right here. So here the pronator teres. We'll be treating the flexor carpi radialis today. We'll be treating the Palmaris longus. We'll be treating the flexor carpi ulnaris. You see that comes this way. The flexor carpi ulnaris, the Palmaris longus, and see how it comes down into the palm. Then here we're going to be treating the flexor carpi radialis and the pronator teres. So let's think about what muscles can cause nerve compression here. So I did I give that to you girls?
Yes.
You did? Great, super. Let's take a look here. The pec major and minor can be causing some ulnar nerve paresthesia. Can cause you could have some radial nerve paresthesia, median nerve paresthesia. You can have musculocutaneous nerve paresthesia. Compression of both cords disturb the sensation, everything below the elbow. So this could be pretty bad from just the pec.
That's a lot.
So the pec is important.
Pec is key.
The pec minor.
It's
Pec major can cause some edema and swelling and in the chest. Triceps can compress the radial nerve. Okay, and I'll show you that. That's paresthesia over the dorsal forearm and the wrist and the digits 1, 2, and 3. So carpal tunnel syndrome would be numbness on this side, digits 1, 2, 3, and half of 4, whereas radial nerve is on this side and half of this fourth. So the two of them there are interesting. So that's triceps we'll be treating today. And we'll be also treating the flexor carpi ulnaris, which can compress the ulnar nerve. That's paresthesia over digits 4 and 5. So that's coming this way, paresthesia over 4 and 5 on this side. Okay, so that would be the flexor carpi ulnaris. The pronator teres would get the median nerve, that paresthesia over the thumb, and the palmar surface of digits 2, 3, and half of 4th. So again, that's this area here and half of the fourth finger here. Okay, so all of this and half of the fourth finger. So this can all be, and then guess what else? We're going to treat the flexor retinaculum. That's what they cut. So when they're giving a carpal tunnel surgery, what they usually do is cut that little retinaculum. But guess what we could do? We could make it longer, so it doesn't absolutely have to be cut for that purpose.
Yeah.
Okay, so one way of treating it would be to make it longer, and then treat all the other muscles that compress on the median nerve. Okay, so that's what we're looking at. And even
carpal tunnel today. Yeah.
And even if you think about the pronator teres and the flexor retinaculum and the look at, if we also want to look at all the C6 is C7, C8, T1, C5, 6, 8. So these are median nerve, C5, C6, C7 in there. So T1. So we want to look all the way up into the neck. Okay, for the nerve root compression. So what I'm saying here is we can treat so much of what's wrong with the hands. I'm dedicated to having all musicians and everybody that wants to use their hands to be able to use their hands.
Yeah.
Yes.
Yes.
Okay.
So correct me if I'm wrong, but that nerve entrapments document is not available on the website currently, right?
Well,
so when you use that, I think you'll want to just take some notes. I can show it to you one more time.
Well, you could take a snapshot of it right now.
Yeah, take some snapshots. I'll give you a moment to do that, if you like. Everything that's highlighted is what we're working with today. Pause for snapshots.
Oh, they're snapping. Look at that. That's cool, you guys.
If you want it. It's pretty easy. All right.
And we got a heart now. Okay, I'm going to turn the page, and we're going to get the others. Okay. All right. So here's the highlighted ones there.
One more moment.
These are the ones for the nerve compressions we're going to be treating today.
I don't think we can play any more of that legally. So we'll
Oh, okay.
Oh, yeah, right. I forgot about that part.
Right.
Okay, great.
I hope you got a good look there.
So I'm so excited that we're looking at this today, and that everyone can see it. Yeah. So we could just take a look here. You can look at some of these great nerve pictures that I have, but you'll see how the ulnar nerve can get compressed by the flexor carpi ulnaris. You can see here how the not only the pronator but the flexor digitorum superficialis can also do a significant compression of the median nerve, and you'll see that you can see now how it gets the thumb and all the way to the fourth finger. Then this was the other one we're treating today, is gets these fingers here. So those are some of our great things we're watching, and then also with the triceps, this is the pain pattern from the radial nerve. So those are the interesting ones we're doing today. Let's take a look at some more of the pain patterns. Let's look at the pronator teres. It has a pain pattern besides causing compression of the median nerve. So here is the pronator teres pain pattern, and I'm going to. Oh, I'm going to.
Now on the second most likely.
Yes.
Right?
Yes, correct.
We talked about the pronator longus, or Palmaris longus, and
Stephanie,
now we're on pronator teres.
Where's the little? Can you come over here for a second? Can you find the those cards? We'll just keep looking for them. Okay. Because it doesn't show a good picture there. Okay, so they're out of
we'll have to do. It's just the Bible of myofascial treatment therapy.
Yes. Okay, so while we're looking for that, I'm just going to show you something else here. Okay, so here, so yes, we do. So look at here. So this is the abductor policis brevis, and see how it attaches right there onto the flexor retinaculum. Oh, it fell on the floor.
We found that.
And look at here, the flexor digiti minimi. See how it also attaches onto the flexor retinaculum. And so you see a lot of muscles attaching onto that flexor retinaculum, and we're going to treat those, especially in the next few classes when we get more down into the hand. So here we go. We're going to take a look.
Fun. Those were extra credit.
Yes, that's right. Okay, here we are. So here we are. So serratus anterior. Okay, so we're looking at pronator teres. So here we go.
Second most likely.
Here's the second most likely one here. We're going to take a good look at it, and you see how it attaches here on the medial epicondyle, and then over here onto the radius. So here, so it attaches. So if everyone looks at me, so you can see it attaches here onto the medial epicondyle, and then comes over and attaches onto the radius, and it goes like this. When it shortens, it goes like this, and then especially it also bends the arm. So when you're bent, also, so when you're bent and going like this, you're really shortening it. Okay, so that's the pronator teres there. You can see it there.
Pronating.
Pronating. And so that's a nice picture. Otherwise, you can't see a good picture of it over here.
Yeah, that is a good little.
I hardly can see it, but you can see. But you can see it causes wrist pain right here, right? Okay, so the third most likely to cause pain there is the serratus anterior. So serratus anterior, and so let's take a look at that pain pattern. I see. We have to find where it is. Okay, so let's just look at
anterior now.
Oh, but I know, but it doesn't. I don't see the pain.
Not the pain pattern you want. Oh,
yeah. She just she found a serratus anterior, but it's not for the pain pattern. Okay, so here it is right here. So it's right here. So here's our serratus anterior. But let's look at them right here. They're all so great. You see how here's the muscle. It's on the side of the chest right here. Look, there's the trigger point. But look at where the pain is, all the way down here into the palm of the hand. See, that's the serratus anterior. And let's look at the latissimus dorsi. This huge latissimus dorsi comes all the way down here, attaches from T1 all the way down, all over the sacrum, all over the ilium there. And look at where it causes pain, all the way down this way and into the fingers. It's just, it's outstandingly incredible. Isn't it incredible?
Outstandingly incredible.
And then here's the pec major. And look at where it goes into the, I might have put a little note there. See how it goes all the way into the hand. Here's your pec major. Here's all just right here in the chest. But look at where it goes all the way into the hand. It's incredible, right? And then here's pec minor, also going all the way down here into the hand. So now the triceps, again, it causes pain in the same area and all the way into the hand as well. And let's move a little closer over here towards the these pictures here, and you'll see this is the flexor carpi radialis. You can see it causes really bad wrist pain.
Yeah,
Flexor carpi ulnaris causes some pain here on the outside, but remember they both cause, in addition to that, they can cause this flexor carpi radialis, carpi ulnaris also causes nerve compression. So in addition to pain, so we get pain and numbness. So you can have both. Okay.
One or the other or both.
Yeah, yeah. This is the Opponens policis. This is right here. We'll be treating that today. You can see the pain that it causes, kind of more. And today we're thinking about the wrist pain right there.
And the thumb pain.
Here's again the picture of the Pronator teres, and the Palmaris longus. I guess I didn't find it on this picture. Yeah.
Where's
Okay.
the Palmaris?
Yeah, I guess it's not in this picture, but we already saw it over there.
We saw it over there.
Yeah, yeah. Okay, so
It's a different view.
Yeah. So we have some great. So we'll take a look at the triceps again. We could see.
Sure.
Again. You can see it again here. It comes down into the. So the part that we're going to be treating today is on the inside of the arm right here. You can see how that comes here into the hand. So that's the fourth most likely to be causing pain in the forearm. Then this is 57, protocol 57, and in protocol 57. The most likely one is the flexor carpi radialis.
Just getting a little different view here on some of the ones we reviewed over there, right?
Yeah. And then we're going to take a look at the two. Let's see, two. Here's so the one is flexor carpi radialis. The other one is flexor carpi ulnaris. Then we'll be taking a look at the Palmaris longus. And here you'll see a nice pictures of that. Nice referred pain patterns. And then also we'll be looking at the pectoralis major again. And remember I showed you how it goes all the way down here into the hand. Okay, so it's incredible. And then the pec minor, which it also comes down here into the hand. Now remember, even the scalenes cause numbness into that area as well. So the scalenes cause you to have pain on one side, and then it causes you to have numbness on the other side. So, but we won't talk about so much about scalenes today.
For once. My God. Wow.
Okay, so we're going to be doing some nice range of motion tests. So here's some of our range of motion tests we're going to do today. Okay, so let's take a look over here. We're going to take a look at the ones we're going to do today. So
this is our fin and shiflet range of motion chart.
That's right. You have the fin and
all
shiflet.
the tests you could want. Well,
Yeah,
some
as well as if we can pass these range of motion tests, it's likely we won't have hand and arm pain. Isn't that great? And numbness and dysfunction.
That's good.
Yeah. Okay, so we're going to do the shoulder drop, and you can see here they're laying down. You're trying to make sure that the shoulder. You're going to measure from the shoulder to the table. We're going to want to know if we have trouble with the Wright's maneuver, because if we don't have blood supply to the hand when we take the arm up like this, then we know that the pec minor is so short that it's pressing on the blood supply and probably to the lymph and everything as well. Okay, so we're going to do, let's take a look. We're going to do this one here. We're going to be looking at the hand to the shoulder blade test. And again, we would like to measure from the superior angle of the scapula, actually right at the spine of the scapula, and near the superior angle. And that's going to be important today. And then we're going to be doing the arm abduction against a little bit of resistance. We're going to be, when we're sitting down, we're going to take the arm back. We're also going to do the over the shoulder reach for the triceps. We'll be doing the over the shoulder reach for the triceps and the latissimus dorsi so overhead reach. So we could clap over the head. You can see we're doing that. And then the side that's shorter, that's the latissimus dorsi that's shorter, the hand will come and meet the other hand. We're going to take a look at the supination. We're going to be looking at the Pronator teres. So that's in the flexor carpi radialis, and also we'll be looking at the finger press test, the Opponens policis test. Oh, we're going to do that one, and the Palmaris longus. We'll be taking a look at that as well, and also the pinky to the thumb test, and we're going to do the Opponens policis test. So we'll do a few different great tests.
So to review, we had all of those culprits listed over here.
Yes, that'd be great.
In
So
order of likelihood, which this is borrowed from our pain key chart, which you saw earlier. And then all of those are the tests that we're going to use to see which one of those may be causing trouble in the volar wrist, volar forearm.
They could take a picture of this too.
Yeah, if you want to take a little
they could take
picture of those, that's what we're working with today, and they're in order of likelihood that they'd be causing pain and dysfunction. This is I think there's some new people who are asking some questions, so I hope that clarifies a couple of the things there. Yeah, and again, the protocol 53 and 57 that are referenced here, you can download the full protocols on www.myopain.com. That'll help clarify some things for anyone who's curious, who's new to this. That includes a lot of pictures, and it'll include some range of motion testing and some treatment protocols.
Now, these
Unable to take pic. Oh, well.
These can be downloaded.
You can find the protocols. Those will help you online.
Okay, great. These we'll be using today. Now, suppose you don't know what all these muscles we're talking about are. You could download this, and you can see just where we want you to treat. So if you're a therapist or a beginner, you can see, well, if it hurts here, then these are the areas that we want to treat. And then here's the stretches.
Plan, whether it's on one of your patients or for yourself.
Right. And you can download this, and you could use it and give it to your friends or your patients.
So, shall we? Shall we delve into it?
Yes. yes. Okay. So we're gonna do it. Okay. So if I could have Stephanie, if you could come over here for a second. Okay. So if I could have you do the standing, we'll do it standing. The hand to the shoulder blade test. So let's. Everybody, this is Stephanie.
Hi.
And also we have Camille here today.
Yeah.
Well.
Yes, I'm here.
Here's Camille. Okay, so we're going to take a look at Stephanie. And so Stephanie, do you have your shoe inserts in?
I think I do today.
Yes.
Good. Okay. So we're going to just take a look at Stephanie.
Take some measurements.
Yeah, here we got our different tools. We have a few different tools for measuring.
Yeah.
Okay, so I can
tape measure, a ruler, and
Yep.
you've got.
So you can see here right now, Stephanie is a little bit uneven. So we'll see if we can. So one.
So you're measuring where the spines of her scapulas are.
Yeah. So you can see that so if you look at if you had something bigger, you could see that if you look at this spot and look at this spot, and then
That's
you
bigger
can see.
than she is.
You see, it's not even. So we'd like to make it. We'll have to see if we can correct that.
Okay.
So that's something.
So we'll tell you how.
Yeah. We'll show how to do that. Okay. So one thing is her standing posture. Back. Right shoulder up. Okay. Let's look at the hips. So let's see how
It's important to measure at the shoulder and hip.
The hips are even. So this
they'll
is
tell you
even
different
here.
things. Yeah.
Mm-hmm. Okay, so we'll try to figure out why she's.
Yeah. We sure will.
We'll work on that. Okay, so we're gonna do the hand to the shoulder blade test, and she passes that. Oh, and
my goodness.
flying colors. Okay, so you can see here. So it'd be like she's like one. So if you measure from the middle finger to the spine, so she's like 1 inch.
Pretty good.
Okay, let's go to the other side, and here on this side. So from the middle finger to the spine, and she's like 1/4 of an inch. Okay, so she
What a
aces
reach.
those.
What a reach.
Yes, aces those. So that means that these muscles here are in pretty good shape. So showing that. So it was the right was minus 1 inch, and the left was minus 1/4 inch. Okay, so that's very good. So we can have you do the arm pull back one. So we're just going to have you sit for that one. So often we have you sit for this one. You can sit there. So this is going to be testing the pecs and the anterior deltoid, the coracobrachialis, pecs major. Okay, so here we're just going to take the arm, take it, and we're going to take it. Go ahead and take it back, the thumb down, and we should be able to get it a little further back than that. But that's pretty good. That's pretty good. That's an almost pass. So we want to get just a little better than that. Let's take a look at the test over here. So here's the arm pullback test, and so that's so you're looking for the arm goes straight back, and it should be level with the opposite shoulder. So it should go a little further back. So just a little bit.
restriction.
Yeah, yeah.
Okay.
Okay, let's go ahead. We'll take this and we'll take it back. Yeah, so we have a little restriction, and you know you have a little bit there, right?
Yes.
She would feel it. She would agree with that. So we need a little work on that. So that's not quite completely there. Okay, so let's go ahead. We're going to look at the. So let's have you stand up again. Let's do the over the shoulder reach. We're going to put her
Triceps.
for the triceps.
Yeah.
Whoa, that's very good.
Wow.
Okay.
What
And
triceps?
The shoulder reach.
What triceps?
Woo, that's
Such
really good.
triceps.
That's really good.
Triceps.
We're passing that one. Okay, so for everyone who's watching, so you want to be going ahead and getting your arm behind your ear, you know. So you get your hand to the shoulder and take your arm behind your ear. Yeah. Okay, so that was good. So we did that. That was really, so that's passing. The over the head reach. So you're going to clap your hands over your head and hold them there. Good. And she's a little shorter on this side. So you can see that these fingers are just a hair. So it shows probably the Latissimus dorsi maybe a little tight on that side. So so the over the head.
It's a little imbalanced.
Mm-hmm. Probably your lat there. So a little bit on the right. Okay. Okay, so let's go ahead and let's do the external rotation here. Woo, she can do that. Let's go internal rotation. So here, it ends here. That's subscapularis, but also a little bit of the lat. Okay, so a little bit of lat. Okay, so let's go ahead. We'll look on this side. So you want to get, for this test, you put the person into a right angle. They should get a right angle plus for a pass for the test. And they should get a right angle also, internal rotation. And so we have a little trouble with that too. So the internal
So you
rotation.
wanted her tips of her fingers to be pointing down?
Down, yeah.
Yeah.
So you should be able to right angle plus and also right angle plus, you know, without like
Without much resistance.
yeah, without substituting other muscles.
Right, right.
Okay, so
No
so
overcompensating.
external pass, internal fail. Okay, so the internal would be a little bit of some of the muscles that we're working today. The anterior serratus test is better lying down, but we can do a little bit of it standing, and you can put the hand here with the fingers and thumb forward, and then you feel thumb forward.
Thumb forward.
Thumb forward. Okay, but then you see a little
No
resistance.
fashion poses.
See, a little resistance.
Little resistance.
So you know,
yeah.
it's a little bit too tight.
So you're looking for it to go
So that'd be
beyond the side of
your
your
it
torso.
should be
Yeah.
it should come back to where the scapula is,
Yeah.
and it shouldn't feel resistant like that.
Middle.
So that's the
back.
anterior. That's the pec muscles we're treating today.
Mhm.
There'll be the deltoid, which we're not treating today. Okay, and the anterior serratus, which we are treating today. A little bit maybe of the lat, which we are treating. Let's look at the other side.
Seems like the lat is a common factor
It's
for
such
her.
but it causes so much pain into the
Yeah.
hand,
Yeah.
the lat. It's just amazing. And also the funny thing is it causes pain in the front of the shoulder. So and in your elbow. So it's just a crazy
What a
muscle.
Yeah, it's not one you would think of.
No, it's very hard to figure out why. Now here again, see, it doesn't want to go back. See, it should go back easier. It should have a soft stop.
Yeah.
So we know we're having a little trouble with the anterior serratus. So we can
Anterior
measure it more
serratus.
carefully when they're laying sideways. So we know that we'll probably have to correct a few muscles. Okay.
Mm-hmm.
So this is our little test today. But I have a couple more. Okay.
Couple more.
We're gonna do a couple more. We'll do a couple more. Okay, so we're going to look at the hand and dorsi, but of course we're not treating those today. So I think I'll skip that one. We're going to look at the Opponens policis,
Yeah.
and that's important.
What a name.
So we're going to take a look at the Opponens policis. But I'm going to quickly do a couple more, okay? Just quickly do a couple more. Okay, so I want to be, for the Opponens policis, I want to be able to get the thumb behind the palm, okay? You can see it doesn't want to go there. Now, let me demonstrate. You should be able to get the thumb behind the palm more readily, and then that means this muscle right here is long enough, okay? And that could cause some pretty significant pain here in the thumb. and so it could definitely cause a lot of trouble. So that's important. And we want to get this finger to come and touch this one easily. And you see, that's the first interosseae. It doesn't want to do it.
So that's a little extra credit for hand issues in general.
That's what we'll be doing these in a couple days.
Yeah.
Okay. So then this one wants to go, see, it's supposed to go that way more. Okay. So this isn't the first interosseae, the digiti minimi. Okay. All the other interosseae are a little too tight. Okay. So these are all bothering her. Okay. And then here's our flexor. It's too tight here, so her extensors are too tight. Her flexors are good. That was good. Oh, that's excellent flexor.
So she's
not
quite
so good
getting a right angle there,
on the right angle. But correct. So you're looking. So you're looking to have a right angle plus, and it should be soft ending.
Yeah.
I've gone to many conferences where massage, all different, all kinds of therapists are at, and almost anyone. No one's passing these tests.
Yeah.
And so I sometimes have a line of numerous people waiting, and I get them all to pass the tests.
Yeah.
So you got to pass these tests. You can't be
It's
not passing.
hard.
Let's look on this side. Okay, so we're gonna look at so the Opponens policis does a little bit better on this side, right? You feel so. Can you get it? Can you get it to state? So it's still a little bit bothering you. This better. This hand's better. Oh yeah, this digiti minimi is not working properly. The interosseae are better. This one here is bothering you. Okay, and this is almost pass. Okay, so it's right angle, and it's a little bit of, and then let's look at the okay, pretty good on the left, but needs to be just a little better. Okay, so we're going to take a look at some of these things. Okay,
Yeah.
see what we find.
So let's review. What did we find was troublesome for her that we're treating today?
Okay,
it was
so we found
Latissimus dorsi and the anterior serratus primarily,
Well, let's hear that we had trouble with the Opponens policis. Okay,
and the Opponens policis.
we did have trouble with the first interosseae.
We're not going to do that one today.
We probably won't do that one, but you know,
Technically.
it's so fun to do it. We might do it. Okay,
Just for fun.
we'll do this one when we lay down. So we'll see if the pecs are holding your shoulders up. We passed those, but we did fail the arm pull back. That's again the same one. That's the pec ones. We did find that her right shoulder was high. So the right was high. So that's interesting. Okay, and we're going to take a look at her nerve roots. Which nerve roots are we going to look at?
Let's see.
We're going to look at C5 to T1. Okay, so we're going to look at that for sure. But even for, so we're definitely going to look at those. And even the Latissimus dorsi, it gets its nerve innervation from up here as well, even though it attaches way down. And let's look at, we'll open the book for do that. So we're going to look at, so we're going to look at why is she uneven. We're going to look at some of the muscles that didn't, the pecs. We're going to be looking at internal shoulder rotation, the anterior serratus, and we'll look at some of those forearm muscles that didn't pass. So yeah, and so that'll be good.
We're going to take a look.
We're definitely going to look at them. Okay, so we're going to get some of these things off of the table here and set up the table for us to treat.
We've been alternating doing focused on treatment and focusing on range of motion and self-care. I guess we do range of motion every class, but we've been alternating classes where we focus a little more on treatment and a little more on self-care.
That's right.
So last time we did emphasis on self-care. Today we'll do more treatment.
That's how we're doing it today.
Yeah.
Okay, so we could get rid of that nice warm blanket, huh? It's warm. What's the temperature in Chicago today, you guys?
47.
It's warm.
Earlier
right?
it was.
Earlier
Yeah.
it was like 52.
It's so different when we walk in from when we walk out. So sometimes what we might do before we get on the table is warm up with a nice warm blanket or like a heated blanket or potentially a hot water bottle. It's always a good thing to do that you recommend.
So we're going to take a
before
look at
treating
your
an area.
nerve roots a little bit, okay? So, but we're going to do that in a couple different ways. But let's do it standing, and then we're going to do it laying down. Okay, so let's do it standing. So we're going to take a look at her nerve roots.
Okay.
Oh, she's got something great on underneath. Super.
Something
So it doesn't
very
have to
handy
stay
for
so-
treatment.
Yeah. So
It's easier to maybe see.
yes,
There we go,
super,
there.
super. That'll be great. Okay. Okay, so we're going to just see standing how's our nerve roots? So we're going to go here. So here's our C1, C2, C3. So for the ones we're going down. Okay, so we're seeing here.
We're doing some skin rolling.
Yes, skin rolling. So here, so here now into the T's. So here the T's, she's having a little trouble into the T1. So that area there would be good to treat.
Noticing a little less easy skin rolling in those areas.
Yeah. A lot of areas could be a little looser in the skin rolling. Okay, but today but the areas we're going to be concerned with today is C5 through T1.
Yeah.
So this is the main area we're going to be thinking about today. Okay. So we're going to do that a couple of different ways, but we'll start with we're going to treat the most likely muscle. Okay. So let's we're going to treat a couple. So let's have you lay sideways.
All right.
Okay, we're going to just take a look at the anterior serratus. We're going to measure that, and then we're going to also do the other test with you laying on your back. So
can I take your glasses, Stephanie?
Oh yeah.
So are you having some trouble with these areas, Stephanie, that you've noticed, or?
Lately, yes.
Yeah. What's the pain and dysfunction you've been noticing?
It's like harder to move my arm back. Or,
Little dysfunction you've noticed? Yeah, more than pain.
Now, Stephanie is one of my apprentices, and she does especially she does a job where she uses the computer a lot. HR. Yeah. So she's doing that. So so remember we did the standing. So I just thought I'd show you. This is how I do it laying down. So this is I think the third most likely to cause the pain right here. Okay, so and that is 10.5 inches. So that's pretty significant. So you can see that.
So ideally, you'd be looking for more like 5 inches.
5 inches.
So she's
something
reaching
like that.
about halfway.
Yeah. So that would be these muscles here.
That will depend a little bit on the person.
Here. Right.
Yeah.
Let's have you turn over on the other side, Stephanie. And one of the underlying perpetuating factors that we can have in hand and arm pain is sleeping in such a way as you squish your arm.
Of course.
Really bad. It's really bad arm squishing. So here you can see that I've got it set up. Also, if I could put this under your neck.
Yeah, she's got her arm.
So we can really get
her neck nicely cradled there.
Yeah. So you get that really. So it could be just a little bit like that. Yeah. Okay. And then the neck is really supported well, and that's going to be great for. Many of us who've got really bad hand and arm pain might be causing dysfunction all night long.
Yeah.
Okay, so here, this is 11 inches on the right, 11.5.
Worse on the right side.
Yeah, we did notice that was a little worse.
And you're
on the
right-handed, right, Stephanie?
Yes, yeah. And then let's have you sit up again. We're going to do the one more test with you laying on your back. This was the we're going to measure from your shoulder to the table, okay? And see how your pec is, because we noticed the pec was giving you a little bit of trouble.
I can feel that.
Go lay on your back this time. But it doesn't look like it's so far forward, but this is one of the tests is you can see if the shoulder, how far up the shoulder is from the table. And it's not that bad. So let's just take a look. So from the acromion to the table is 2 inches, and on this side, you can see me measuring, and that's 2 inches. Okay, so 2 inches, 2 inches, about 2 inches. Okay. All right, so we're going to take a look at all those things. So what's the most likely one to cause forearm pain is Palmaris longus. So we're going to start with that one, okay? Second most likely is Pronator teres, all right? Third is the anterior serratus, so that's what we do with you laying sideways. And the fourth is the triceps, okay? And it's the inside of the triceps right here we're going to be looking at. So we're going to look at the Palmaris longus, which is the most likely one. Okay, so it's attached.
Okay, starting at the top.
It bends the arm. And one of the things I find is people go around like this. They have their arms bent all the time, and they sleep with their arms bent. Yeah. Okay, and they got sleep. Well, look, they're always sleeping like this, with their arms all bent. And all these muscles today, many of them cross the arm, cross the elbow, and cross the wrist too. So this really shortens them. Okay, so what if you wake up and your hand is like this when you wake up like that? That might be because you do a really repetitive task, like maybe cutting something, chickens or something.
Okay.
Chicken stuff.
Cutting chickens.
I've had people come in with that.
Okay.
They work for a
Take a poll. How many people in our audience are chicken cutters?
How many people eviscerate chickens for a living? Hey, it's a thing. Whatever.
We want to know.
Okay, so I can feel
Some kind of repetitive task.
Yeah, that's
Sleeping or eviscerating chickens.
That's it. Okay, so here we're going to take a little look at Palmaris longus while we're treating it, just for fun. So you can see it crosses the elbow and crosses the wrist. See, and look, it goes all the way into the palm, and it attaches, but it also attaches on the flexor retinaculum, the thing that we cut when we have carpal tunnel surgery. And how much is carpal tunnel surgery, you guys?
How much?
Mm-hmm.
I don't know. They don't give you a quote beforehand.
Never do.
It's a lot.
It could be a lot. Could be a lot. Yeah.
So we're treating that.
Mm-hmm. And even the cold pain could be significant.
True.
So here I'm treating the attachment of the muscle right here. Remember, it causes pain in the palm and right here. So so we're gonna. So I'm treating Palmaris longus, the most likely one to cause forearm pain right here. Oh, what does it do? You go like this, so everybody, it cups your hand like that.
I see.
You see, it also bends the wrist and bends the elbow. Okay, so it helps to bend and it helps to pronate when we're typing like that. Okay, so we can feel it doing its job. So here, I'm right on the muscle, and its trigger points would tend to be about here. Okay, what do you think, Stephanie?
You feel
Okay,
that.
so we're gonna feel it pronating. We're gonna feel it flexing. We're gonna feel the wrist. So
to take the muscle through its full range of motion.
Nice to see what it's doing. You can do that. When you wouldn't do it is when you put it in the short position and it goes into Charlie horse.
Yeah.
Then you know, you better put it on the stretch position.
Yeah.
Till we can do. So I'm right on it. Can you feel it?
Yes.
Mm-hmm. Yeah, we're right on it. Yeah.
Stephanie's feeling it.
Mm-hmm.
Rest assured.
It's coming
We're
down.
using knuckle right now.
I am doing that, and I
Excellent
may
tool.
use another tool soon.
Stay tuned.
Sometimes I like to use this knuckle, and sometimes I like to use that knuckle.
Wow.
So many knuckles.
You see, you could use different knuckles at different times.
Or both of them.
Yeah, you could use both knuckles. Like both knuckles. That would work too.
It's a little broader pressure, I guess. Yeah. Are you think you're gonna delve into the elbow?
How did you know? She knew I was going to do it. She knew that the time has come for the elbow. So if you have a high-low table, when your arm's extended, you can have the table lower down. But when you're going to use your elbow, you might
it up a little.
have it up a little bit. Yeah, like that. So here we're going to come right onto it here, and we're going to come. See, here's where it attaches onto the flexor retinaculum. Okay, and here's where the flexor retinaculum is. Okay, let's look at where it is.
Yeah.
It's right here. So it's right here. This is the part that gets cut. Okay, it's right there. It's between. It attaches here, and I have some really great pictures of that. Some super great pictures that I moved around to put some.
Is it on the cards?
In those cards.
Right here?
Yeah.
The cards are
But they're different loose cards.
Oh, I put them in here.
Oh, you did put them
Behind them.
Oh, you did. Okay,
Yeah.
so then we can find
The
them more
wrist
readily.
ones are in there.
Okay. So let's. Here they are. Look at see all these muscles. See. So you see the digiti minimi, these little muscles here are attaching here onto the flexor retinaculum, and the thumb muscles are attaching. So when we go like this, we're stretching it, and we're going to be also treating that flexor retinaculum. Isn't this wonderful?
Yeah.
We can get that flexor retinaculum to really be longer. Isn't it outstanding? Get right onto it.
That would be outstanding.
Yeah, we can make it a little bit longer. It only has to be a slightly longer to probably take away any compression that would be on that nerve, the median nerve. Isn't that exciting?
Yeah,
We could always
Just to
try
get
it.
onto yeah.
So this is what we should for sure try before we decide to just cut it with surgery.
Yeah.
Yeah,
Worth
we
a
could try
try
that.
before
We could try
surgery.
it. Yeah, we could try it and see if it works. Okay, see how good it does. Yeah, we could try it.
And we have Camille treating herself over here.
Yes.
That's wonderful, Camille. I'm so glad that you're doing
That's a
that
nice
along
way
with
to
what
do
we're
that.
doing. So we're getting
The
both
jack
done.
dubber.
We're getting them both done. So get right in there to that flexor retinaculum there,
Yep.
right there. Yeah, right in there. Isn't it wonderful to treat that?
Very much so.
Leslie
Okay.
said, any thoughts on Dupuytren's? Dupuytren's? Is that?
Oh, okay. So you have to know how to speak French. So de plus, you know, yeah.
Dupuytren. Dupuytren.
De plus. Okay.
Yeah.
You guys, French people, you have to speak the. Oh, you tell us how to say it in French.
I need to see.
De plus. Okay.
Well,
anyway,
We're working on it.
Okay, so
Go on. What
So
about it? Thoughts on
sometimes-
it? What is it?
sometimes that you could have
What is that?
it could be permanently contracted, like it's like
Okay.
people's hands are like contracted like that.
Okay.
Okay, so that could be, and maybe this tendon might stick up like that. So it could be difficult to correct, but it's worth a try, and you can see if doing this corrects it.
So
Okay.
that's the condition Dupuytren or whatever it's called.
I'm sorry, you guys. I just forgot how to pronounce it in French, and I'm not.
But
even
that's
though-
the condition she
Yes.
was referring to. So.
Yes.
So some
Someone
of the
will give us
things
the
were-
correct spelling, and maybe somebody else can pronounce it.
Well, so you think that a lot of what we're treating today might address the same problems
Yes.
that would be at the root
Yes.
of that issue?
Yes, we would,
Yeah.
because we're going to be treating nerve roots. We'll be treating all the
Palmar
nerves,
pain, yeah.
all
Yeah.
the palmar.
Okay,
We're
so
getting
this
right
should
on the
target
muscles.
that.
Yeah. So we'd be contradicting the shortening
Yeah.
that's caused by that, and that's considered hereditary. So you'd have to really for sure check to see if we would be able to correct anything.
It's worth a try.
Yeah.
Worth a try.
Because maybe it's not what they think it is. Yeah.
Yeah.
Now I'm getting all kinds of stuff in that isn't like they call it dystonia in the hands. I get different parts of the face, neck, hands, arms, dystonia, which means like turned to stone. I have excellent results with that, even though it's considered like
Basically
you have
not curable.
absolutely you're done with.
Right.
They don't have any treatment for that. So I have very good results with that. Maybe up to 3 weeks, or even sometimes one treatment. Someone came in. I've had numerous people with in the lip where the lip is turned to stone, but you get it all in the hand too. In the hand, so horn players get it in their lip. A young guy came in, gone, one treatment. Then they pretty much. I mean, people. I mean, if you're the woman that came in with that from the symphony, they were besides themselves, just besides themselves, because they couldn't use their lip. It was like incredible. Okay,
So
so
when you're using your elbow there, it seems like kind of a sensitive little area, but you're not necessarily pressing that hard.
but it feels pretty good,
to
doesn't
be
it?
effective, right?
Yes. So you'll see if you did this on yourself. Everybody, you could try it on yourself. You
I
can
mean,
see.
what kind of pressure would you say you're using?
I'm using a goodly amount of pressure, and it's not painful at all.
Because it's broader, it's
Yeah.
actually probably less painful than
Yeah.
the knuckle.
Yeah. So
to use. Yeah.
yeah. So this could be.
But you're feeling the area.
Yeah.
So you're responding to what you're feeling
Right.
with your elbow.
Right. So what I do is when you're looking for a hard spot, when you touch the hard spot, then all of a sudden you're looking for hard areas and painful areas.
Yeah.
And I have a slight hard area there, so I'm just going to press on it a little bit.
So you just kind of like open up your arm a little bit, which makes
Yeah.
your elbow a little more
less
pointy.
pointed. Yeah.
Or a
So
little less pointy.
this is less pointed, and this is more pointed. Yeah.
I was using the jackknobber, but the elbow is more effective.
It is.
Really
It really
is.
It's much more effective.
Even
much
on
more
yourself.
effective.
You can really feel it, can't
Yes.
you? Yes. So
more than with the jackknobber. Yes.
Totally, I agree with
It
you.
kind of
Definitely.
requires a little less effort on your part because the elbow is such an effective one. Yeah.
Okay, so
okay, great.
so this is
So
our
we worked on the number one culprit there. How's she doing?
yeah, that's very good. So she's got
She's
a really
still
good range of
breathing.
motion there,
Nice.
and she did good there. She this area we were not treating today, it needs a little attention.
Yeah.
Okay,
The flexor digiti.
okay. So
area.
now we're going to take a look at the pronator. So we're going to take a look at the pronator teres. Okay. So let's find that nice little one here.
Ooh,
So it's the
okay.
second most
Pronator
likely here.
teres.
So let's look at it. Here is a nice little picture of it here. And again, it pronates, right? So here it is. Look, it attaches in the same area. So it bends the elbow and pronates here. So, okay? So here, so it bends the elbow and pronates. So what do we do when we type? We pronate. Okay? So we're pronating there. So here, let's feel that muscle. Let's feel it here. Let's feel it pronating. Whoa! I can feel that. Okay. All right.
Stephanie can feel that too.
Okay. So you can feel. So I can feel the dysfunction with that. Okay.
Yeah.
And remember, what does the pronator teres compress? The median nerve. Okay. That gets the thumb, first, second, and half of the fourth. Okay, so
median nerve.
Right?
Yes.
Wowie! I can feel it. Whoa! I can feel it. So coming from here to there. So I feel it doing its job. So I'm going to its attachment right there. Yeah.
Giving you a lot of resistance as you're.
I can feel it. Yeah. Oh, it doesn't want to do its job. Yep.
Says,
No.
Don't make me pronate.
Well, typing.
Yeah.
But I think we can fix all these and keep people in full function.
Yeah.
How long have I been using my hands? Since 1983.
Before that, you weren't really using your hands.
And I was an artist and musician before that.
Yeah.
Okay? And I used my hands all the time, and I was a waitress and everything. But I'm just saying, I've been doing this work where I'm really using my hands a lot.
Yeah.
Since 1983 till today, and I can pass all the range of motion tests, everything, and I have full function and full
You get
strength.
after it every day, right?
Well, I notice every day what I can't do,
Yeah.
and if I can't do something, then I fix it.
Yeah.
Okay, if I don't fix it right away, I fix it pretty quick.
Yeah.
Okay.
You
So-
do like daily check-ins.
I check in. Yeah. So
with your
I
body.
almost treat myself every day in the shower, and I check the range of motion of everything, look for painful
when you wake
areas.
up, you really feel kind of what is dysfunctional. I think we can all kind of relate to that.
A little shorter when we wake up in the morning.
You might feel stiff somewhere.
So I'm just
We can
checking.
fix that.
So here I'm going where it attaches. Okay. So it's a little not clunking now. Okay.
Nice.
Oh, a little better. I found a little bit dysfunction there. Okay. So it's coming along. It's improving. I found a little bit more right here. Okay.
You feel that?
Yeah,
yes.
you noticed that too. Okay. So remember, we have to have full function of our arms and our hands.
Yeah.
We can't have, there's at least 12, 13, as much as 14 areas in the arm that can compress the nerves significant.
Yeah.
Okay. So it's so important.
Constant vigilance.
But also, okay, we're going to have a little break soon.
Yeah.
Okay, so
we'll
we're going
finish
to
up with this area then.
We'll finish up with this, yeah. So we're doing really good. I can feel it's better. So what before, when I moved it was going clunk. It was like going to Charlie horse, it was going to passive. It was just when you positioned it, positional contraction. When I positioned it in this position, it went into contraction, which is not supposed to do if you're just passively moving it.
Yeah,
Okay.
yeah.
Okay. Okay, so that was pretty good. It improved a lot. That was good. That's good. That's good.
You feel
So,
all right?
I'm going to give it a little bit more. A little
Okay.
Bit more. Just give it a little bit more.
Doing fine.
Still
be
needs some
okay.
work, right?
Yes.
Yeah.
Yeah.
Little improvement.
But
though,
which means Stephanie,
that it has some effect.
when
Yeah.
I met
That's what you're
Stephanie,
looking for.
she had a lot more dysfunction than she has now, and so she's been improving just leaps and bounds over time. Yeah.
Yes.
Okay.
She's an achiever.
Yes, she is. All right, so let's
we'll
start
take
now.
a little 10-minute break.
10-minute break. We'll do it.
Yeah. So again, quick reminder for anyone who wants to get CU credits. I know there's some of you out there. Just make sure to stay tuned for the rest of the show. We're going to do one more hour. And at that time, when we're done, you can email us with your Periscope handle, your name, your license number, and the name of the course you watched, and you should be all set. And then, of course, we'll need some contact information to send you your credits. And if you would tell everyone else about it, that'd be great. That's all we ask for these 2 free CE. We'll see you guys very soon. We just got a little intermission. Ooh-wee. it's about time. We are about to resume this class on Volar forearm, volar wrist, and palmar pain, or elimination thereof. We're here again with Stephanie. Again with Stephanie and Sharon and Camille. And our books and papers.
Okay,
and where are we picking up again?
Okay,
we
we're
just
gonna,
worked on the two biggest culprits.
So here this is
for volar forearm pain.
Volar forearm pain, and the
Now we're
fourth
gonna
most
move
likely
on.
is triceps.
But what about the serratus anterior?
Well, we're going to do that
Later.
when we change her position.
That was a big one for her,
Oh,
right?
it's very we're going to get that. We're going to do that in a few minutes.
Now, she was an expert at the triceps, so we'll see what happens.
Well,
here.
but we're going to treat a special area on the triceps that causes pain.
Great. Yeah.
So here you'll see it right here. So we're just going to get right in here. And we're going to check trigger point 5 in the triceps, and it causes pain down here. Look at all the way into the fingers right there, and the anterior forearm
A
pain.
good measure. So this is an example. Like even when someone passes a test, we want to treat the area and actually feel what's going on there, right?
That's right.
Yeah.
That's right. Oh, well, in this case, we're definitely going to do it.
We're definitely gonna do it for your purposes.
Yes, yes. So here we are. So then we got this one. So we're going to take a look at that triceps and look at we're heating her all up. So we made her a heat sandwich. Okay. So we got heat on top, and it's nice and warm. Oh, it feels so good. I'm going to get this one to Camille to use over there. You could
On his arm?
On your.
Oh, I'll use it on my arm. Oh, all right.
Okay, so we're going to take a look at the triceps right here. So we're going to look for. Right there. Yeah.
So you're noticing.
So we're looking for a painful spot.
Or pain.
And we're looking for a taut band. So we're looking for a taut muscle.
So you're feeling some pain, Stephanie?
Yeah, my hand went numb.
And it can cause radial nerve compression. Okay. And maybe a little bit of, we might even see a little bit of ulnar nerve.
So even if you can have full range of motion, like she did pass that range of motion
She
test,
did.
you might
You can
still
still
have
look.
pain.
You can still look in the muscle for, especially flexible people, can have trigger points even though they pass the range of motion test. So if you don't pass the range of motion test, you're more likely to have it, dysfunction. But you could still have significance, so it's good to look. So you always want to look in the muscle to see if the muscle is actually functional.
Yeah.
Okay, so we're taking a look at the triceps. Remember, this goes, where did you feel it? Did you feel it in the fingers?
Yes.
Okay, so this, remember, causes...
Right around this area for some reason.
So we get right into that. So here I'm using two knuckles. Now, when you're treating people, you can't go like this. You can't treat like this, because then your hand, you can't. You
have no leverage.
You have no. So what really is you've
You're
heard me say
leaning.
this before, is when I'm pressing here, I'm actually pushing with my great toe.
Yeah.
So I'm pushing into her arm with my foot.
Yeah.
Because see, my body is braced.
So you're just gently leaning forward. You're giving a nice position that allows you to like extend your pressure right directly into that area. Yeah.
So the triceps, we're doing its job.
Now we're on the triceps brachii.
Okay, this part of the triceps, though, look it. It's helping to pronate.
Really?
I can feel it. Okay.
So
it's helping to pronate.
assisting?
So this one here. So this is helping her to do her typing.
Yes.
I can feel it there. Okay, so it's helping to pronate right there. Yeah.
It's like the muscle just tells you a funny little joke there.
Yeah. Oh,
Keep
sure.
going.
Muscles have a sense of humor. Yes.
Why did the chicken cross the road? To get away from the chicken cutters.
That's it. The repetitive overuse guys. Okay. So now we're going to take a look at a couple other muscles. We're going to look at. Now we're going to go into protocol 57. That's
Into 57.
This is palmar wrist pain. Okay, palmar pain and palmar wrist pain.
Volar wrist pain.
And palmar or volar. Yeah. So we're going to first one we're going to look at is the flexor carpi radialis, and then next we're going to look at the flexor carpi ulnaris. Okay. Then opponens policis. Then we're going to start on those big muscles, the pec minor, the pec major, latissimus, and these here. Okay. All right. So let's take a look at them. I have a nice picture of them. Let's see. Oh, I must have lost my thing there. Okay.
We'll find it again.
We'll find it. Well, here's. Let's stick it on the triceps. Okay. So here's our flexor carpi radialis and our flexor carpi ulnaris. So here they are. And you see how they attach onto, so they bend, and they attach onto the humerus, again, on the inside here. Then they're going to bend the elbow, and they're going to bend the wrist, and they attach down here into the base of the second and third metacarpals. Okay, so let's take a look at that one.
Inside of the forearm there.
Yeah, so it's going to bend the wrist, it's going to bend the elbow. Okay, so we're going to look at it on the short. I'm going to feel it shortening. And then it goes to the metacarpal heads here in the hand. Stretch it, contract it. That you notice right there. Yeah. So I can feel
there's
some,
a little resistance.
So I can feel some dysfunction right there, right here, right there. So we got some taut bands right there.
Attachment.
Well, it's not quite the. It's
Not
a
quite.
little, yeah, it's a little bit below. So I say it's about right here, right there.
Okay.
So here we are. We're right on it. So I'm going to stretch it, contract it, then stretch it. Let's come down all the way to where it attaches. Okay, right where it attaches onto the metacarpals, right there. So I'm just checking it again, shortening it all the way. And see, you want the arm to totally bend like that. For all of us musicians, we have to have our hands. Now, I said to one musician about 25, 30 years ago, I said to her, this violinist, I said, do you want the owner's manual for fixing your neck, shoulder, hand, and arm? She said, yes. That was like 30 years ago, and now she plays better now than she's played in her whole life.
Well.
She has.
The owner's manual is within your reach.
Yeah, this is what you have. Okay, now we're going to look at the ulnaris. Let's take a look at the ulnaris.
Okay.
Now let's look at the attachment of that. So you see it attaches onto the humerus. It attaches onto the to the ulnar. Okay, it attaches right there. So you'll see. So it's attaching way up here, so it bends the elbow. Then it's attaching right there. Onto the electronon, so it attaches onto the elbow. And then it's going to attach onto the whole forearm, and then it's going down here and attaches onto the pisiform, the hamate, and the fifth metacarpal there. Okay, so it's got a lot of places, isn't it incredible? Remember, these cause wrist pain. So this causes wrist pain, and wrist and finger numbness here. So numbness because it can compress the ulnar nerve. Okay.
They're asking, what instruments do you play, Sharon?
Oh, I play a few instruments. So I've been playing my ukulele that my mother gave me. Well, I don't know even how long ago. A really long time ago. And so I've been playing that.
Your baritone ukulele, right?
And I've been playing this. I've been playing this.
It's a galele.
It's a
Or a
galele.
gitalele, sometimes
It's a
called.
guitar-lele.
I call it a lot of things.
Yeah. So, and then I play
I know, like a
guitar.
little guitar.
I play guitar.
Yeah.
So guitar, ukulele, and some other instruments sometimes, but that's what I'm doing right now.
That's your guitar is your primary instrument.
Yes, it is.
And
yes. Voice and guitar, yeah.
Which, you know, if you're a singer, definitely there's some very important self-care you'll need to pay attention to as well. Less in the hands, but
Yes.
it's definitely an instrument.
So I helped numerous times opera singers, you know. So how's this feel here? She feels it, yeah. So I can feel some attachments there, where I can feel right where it attaches onto the ulnar. Yeah, I can feel it. Oh, she feels it too. Yeah. But I have worked with opera singers, all kinds of vocalists, and help them. And they're traveling all over the world, and I hear about them every so often.
Yeah.
So we're right on it. So we want to do right where it attaches. So we're going to go bend it, do its job. So we're going to bend it. And bends the wrist too. Okay, so we're bending it. And let's stretch it. So we'll treat it while we're stretching it.
So these are a lot of, there's a lot of muscles in this area that kind of overlap each other.
They do. There's 3 major layers.
Yeah. Okay, so it's helpful to use the knuckles in this case because you kind of need to find the exact one, right?
Again, I just change around.
Still helpful to use the elbow, but it is a broader pressure, and sometimes you might need to get right at the muscles and especially the attachments.
I just like to change it up. Right? Yeah. So say for instance here. So here, if I use the elbow,
right on it. Yeah.
I kind of use the elbow and kind of grab the tissue and roll it in. So the elbow. Yeah. Stephanie, tell about the elbow, the way it feels now compared to my pointy knuckle.
It's a little bit more stronger.
But so it's a little more deep.
Yes.
A little stronger. Is it more painful?
No. It's a little less than.
Slightly less painful.
Yes.
Okay. So that's just about the way it is.
So if you're like, so it looks like you're kind of holding her arm in such a position.
Yeah.
That
so holding
helps
onto
you
it.
Access that particular muscle,
right. I am. Yeah. So
that's
I'm grabbing.
Part of the key of it. If you're using
it's getting really close to the ulnar side, the little finger side. Okay. So getting right into the little finger. I can feel I had some taut bands right here. I've gotten really good to working through my elbow, and I could feel taut bands. But not only that, I could feel taut bands through your elbow. Like I could take your elbow, put it here, and I could feel the same taut bands through your elbow. Because I've gotten really good at feeling through tools nowadays.
What do you mean you could feel it through her elbow?
Come here.
Well.
Take an elbow.
Okay, so here, so here I can feel that right there. So I'm right on the taut bands, right there. Right?
So you just begin to feel kind of some resistance, right?
I can feel it. So here, right through her elbow, I can feel the taut bands. It's almost like I'm there. It doesn't even feel like I'm not doing it. It's almost like I'm doing it.
Because there's like a change in the texture of the muscle, right?
Right.
Yeah.
And so
maybe different textures, but it's going to be a little bit different than whatever the less or whatever the more.
Okay, so the tissue should feel really easy to press on, you know, when you're not contracting it.
Right.
Okay, but if it's dysfunctional, you'll feel the taut band.
It sticks
It
out.
feels hard.
It makes
right
itself
there.
known.
Yeah. See right there, I feel the
you
hard
go over it.
dysfunctional muscle right there.
Okay.
And I'm gonna right there. Oh yeah, that feels a little bit like the Pronator and the Supinator. Yeah. Okay, so it's good to get in here and treat everything.
Yeah.
To get at the little finger side, sometimes you can use your elbow and then grab it like that. Yeah. So this could be a really great way. And I had so many people at different conferences, all complaining, therapists complaining about how their thumbs are hurting.
Interesting.
And
so why was that?
Keep in mind, I have no thumb pain.
Yeah.
And I never have thumb pain. And
so it could be for a few reasons.
I make sure that I can pass these range of motion tests.
Yeah.
So if
a lot of the ones that we're treating for this sort of block apply to the thumb pain. And
this is like, I will not tolerate dysfunction in these muscles.
Zero tolerance policy.
Yeah, pretty much. You know,
for your own body.
Yeah, just pretty much it. Yeah, that's it. So here I'm going to come down to where it attaches here, onto the pisiform. The pisiform and also the hamate. Right there in the pisiform, hamate.
All the little attachments.
And then onto the fifth metatarsal head.
Or the ulnar.
Carpal head, metacarpal head.
Right.
Oh. Okay, great. Let's see how we're doing. Oh, well, we're bending it quite a bit better. Look at this. So before I thought that was your extensors, but it was your flexors. Okay, okay. Didn't want to contract. Okay, that was interesting. So usually that test there would be testing more of the extensor. So here before when we tested her, she didn't pass the extensor test, but now she is. Why? Because the flexors are now flexing. They were refusing to flex before. Okay, so that was it, huh? They didn't want to do their job. Okay, so now I'm going to do the let's see, the Opponens policis. Okay.
Oh, Opponens policis.
Okay, Opponens policis. So we're going to look at that. I was wondering if we could just also look at it in our book here for a second. Let's look at the Opponens policis.
Let's do it.
Is this it? No, Pectoralis. Opponens policis. Here it is. Okay, so here's our Opponens policis. See, it causes really bad wrist pain. Okay. We're going to treat that Opponens policis there.
Big thumb pain culprit.
Okay, we'll put that this right here for a minute. Okay, so here, remember, we're going to get this behind her first finger here. Okay, so this is a little painful, she's saying.
This is a mouse.
So sometimes, if I'm out to dinner with somebody, I'll fix this while I'm waiting for someone to serve us.
Yeah.
So I'm fixing this. Okay, so here I can feel the taut bands don't want to contract. So what does it do? It poses this. So if you don't have that, you don't have any strength in your thumb. You know, so you want to be able to have full strength in your thumb, and you don't want to have that pain here, pain here. Okay, but look at it's passing the range of motion test here. See, it's almost passing it. It's almost passing it. Yeah. So it's coming along. No, it's amazing that this itty teeny, look at this little muscle. This such tiny little muscle could cause that much pain. You know, right? Well, how could it cause?
For the hand, don't you think?
Well, it's only just this big here. It's only from here to here, so it's not that.
That's true.
It's not that big. But look at here, what it attaches onto. It attaches onto the flexor retinaculum. Yeah. Look at that. It's attaching onto the flexor retinaculum. Yeah. So it could be affecting the carpal tunnel ligament there. That flexor right there. So I'm right on that. See, right on that flexor see, it attaches right there. I'm right on that flexor retinaculum. Right there where it attaches.
Where it attaches.
Right there. I'm shortening it.
That causes
lengthening it.
There, yeah.
We can't accept this. This is unacceptable dysfunction. You can't have this dysfunction. You can't. You can't live with this.
It will not stand.
You cannot live with this dysfunction. I will not tolerate this dysfunction. And I just want to say hi to all the people that watch the show on the rebroadcast, on the archived broadcasts.
Yeah.
You know? Yeah. Or
hey,
the
everyone.
rebroadcasts. Yeah. For everybody, for those. So I just want to say hi to everybody who watches it later down the road. Sometimes thousands of times. Yeah.
Yeah. Thanks for watching.
Yeah.
Both live
and remember, you have to
rebroadcast.
have full function of your hands.
Yeah. I keep reminding you about that.
Yes.
Hands first.
Hands first. No.
Because the hands will be what help you fix the rest of you.
That's right. That's right. So here, this is starting to see, it's starting to pass. Okay, but it won't stay there probably. Oh, it was almost staying there.
Pretty good.
Okay,
much better.
It's almost passing. Okay. Well,
not quite.
Not quite.
Well, it's closer.
I think you want to be flat, right?
Yeah.
Yeah.
It's you got to have the thumb. You have to have the hand here, and then you still be able to get the thumb here. Okay, it's coming. It's almost there. It's almost there.
You're working on it over there.
Working on it.
Opponens policis.
Oh, it's coming. It's improving. She's getting it. She's getting it. That's good. That's good now. That's good with the heat. Now look at how you could actually have like a heat sandwich.
That's right. With this
you just get your hand in there like that.
Get it all the way in there.
That's so great. And us musicians, if we want another 20, 30, or 40 years of being musicians, and if we want another 10, 20, 30, 40 years of being a massage therapist or a hands-on therapist, a body worker, we've got to have our hands. We need hands.
They're handy.
Yeah, they're handy.
I'm sorry.
I love it.
Sorry.
Okay, I'm going to also, this is really good to use your elbow on. Okay, so I'm going to just demonstrate it on myself. Okay.
Stephanie has this look of dread on her face.
That's a very common expression here.
See, you get your elbow right on your thumb, just like that. Okay, so we're gonna. Everybody, I want to tell everybody in India, everyone in India who's on computers, you need this class. You need to know how to fix your arms and hands. The entire.
You're saying because it's a big industry there.
Yeah.
For people to be on computers.
Yeah, huge industry. They got to be able to do it. Yeah.
Whatever country you're in, but hello specifically right now to India.
Hello, India.
Hello.
Oh, that's looking very good. Look how it's laying there, nice.
What a good thumb. What a good opponent's policies.
So here we're getting right on it. I'm a little bit on your adductor policis.
Yes.
Your yeah. So, yeah. Right in there, yeah. Okay, so let's see how we're doing. Oh, we're turning into a thumb.
Turning into a functional thumb.
A real thumb.
It's a frozen thumb earlier.
It's going to be a real thumb. Okay, so we're doing really well on this thumb. Let's take a look at the flexor retinaculum again. So we're going to stretch. Remember how these muscles attached onto it and these muscles attached onto it, numerous? So we're going to stretch it a little bit there. Isn't that great?
How's that feel?
It feels good. Not painful.
Good.
Nice.
Now, I don't think one spot that I pressed on was painful on me. Not even, I don't think, but I mean, and I don't work on it like day and night or anything. It's just that I'm just after it, enough.
When you do have the issues.
Yeah, I'm just after it adequately enough, yeah.
Well, and partly, just like anything, it's a matter of doing what you do in a healthy way so that you're not creating some kind of perpetuating factor.
I attempt not to create it as well.
So that's part of the positioning that you recommend.
Then how I use my hands. Yeah, like I say, almost any convention that I go to, any meeting, everybody can't pass these range of motion tests. I don't think I can get. Almost nobody.
It's very common.
Hardly passes them. Yeah.
Yeah.
So I could have a line.
Yeah. Well, we're very used to. It's
So outside here on Michigan Avenue have a line too.
Yeah, it's
Okay,
so
now-
common that we're used to living with it.
Now we're
But
going to
we don't
take a
have
look
to.
at the anterior serratus and the Latissimus dorsi on this side, okay? So we're just going to change the position of you. So we're just going to move things around a little bit.
This was one that was giving her a little bit of trouble.
Yeah, we were going to see if the Latissimus
Interested to see what
dorsi-
happens.
So if I could, I was going to have you go ahead and sit up. Go ahead and then stand up for a second, or just sit there while I change my pillows. Okay.
You want to take these off?
How you feeling, Stephanie?
Yeah, you
Overall,
Put them on top.
moving around.
That's great. Yes, thank you.
You feeling a little more functional?
Yes.
I had no idea.
Nice. You're gonna have to get after your whole other side after this with some self-treatment, right?
Yep. Have to.
Okay, so we're going to have you lay sideways, put your shoulder in the little crevice. We'll see if we have a nice neck roll. Here we go, a nice neck roll. Okay, so remember we had...
Look how comfortable.
So we have a
you
little
wanna
bit of
be
dysfunction here. Oh, the arm is a little bit better even without
Yes.
treating it. So from treating the
Look at that.
hand
Oh, that's great.
and other
It is
muscles...
improved.
Do you want to measure it again? Because it was about 11 inches.
It is better, yes, and we could check it. Yeah.
Did we measure her while she was sitting on this before?
I
I'm not
think
sure.
so, yeah, we did. Yeah, it was on there. Yeah, 9 inches, 2
9
inches better.
Okay,
Yeah.
great.
Wow.
Yep.
They say, we love Stephanie.
I love you guys too.
So, treating the serratus anterior?
Remember, there's 9. Yes, there's 9 different muscles, and it attaches on 9 ribs. I'm right on it. And
What
then
a muscle. This
it's
one
the
causes a lot
anterior
of trouble.
serratus. Yes, it does, and it causes pain all over the. It causes really bad elbow pain.
So the position you've got her in
mhm.
here, that helps you get access to all the
Yes,
rib attachments?
That's correct.
Mhm.
And it attaches on the medial border of the scapula, so the anterior medial. So it's so here. See, I'm levering the scapula off of the rib cage here. See, so I'm pushing, so I'm getting
You're
further and further
exposing it a little
down
bit, yeah.
into it. Yeah.
Should I look at the pain pattern
Why
for
don't
that
you go
again?
ahead? Yes, right there. You'll see it
that.
right there.
It's treating
And look at how it goes into the hand there.
Yeah, it's what a position. Yeah, that's really key. Yeah.
And that's a
Otherwise,
mousing
it'll be
muscle.
in the
This
way.
is one of your major mousing muscles. And you can look at it causes elbow pain and hand pain.
Yeah.
And pain between the shoulder blades.
Yeah.
It's starting to be a little bit more relaxed. Yeah, I can feel it a little relaxed. So
you're applying some general pressure, kind of
Right.
with a little bit of your bone, which bone is this? Your ulnar bone?
yeah, this is the ulnar, and this is the olecranon.
Yeah. So you're using kind of like the
Right,
edge of your
right,
forearm a
my
little
forearm,
bit. because
right,
the
correct.
serratus anterior is
Correct.
kind of big.
Right.
So you're kind of accessing.
And here I'm
accessing
using
a lot
my.
of that, and you're kind of moving along the area that the serratus anterior.
So
covers.
before I might have been using my right arm some. Now I'm using my left. One time I broke my right elbow. Do you remember that?
I don't remember it. I know about it. I don't remember it because I was like 1.
Yeah.
Yes, she sacrificed her elbow to save my life
Oh.
because I was a little baby and
Yeah.
she slipped on the ice. And,
Black ice. I had a
landed
cat.
on her elbow.
I had a cat in the one arm.
And did the cat survive? Did the cat survive?
The cat survived too. Reva survived, but I broke my elbow, so I had to hire somebody to be my right arm.
Oh wow.
So they were my right arm for several months.
Wow.
So if I would use my left arm, but then I'd have them move the person and be my right arm. So it worked. They were my right arm. But how isn't it horrible to?
So we have to have the use of our arms so we can save babies.
That's right. That's right. Saved her little head.
So she's treating herself a
This
little
is torture.
bit. Yeah.
She's
She's
so
using
this is
a
a great way
broad
to treat
ball.
the anterior serratus. She's treating some really, this area here is often what gets dysfunctional from using the mouse. So we're right on it, and it causes elbow pain. Now I had the Chicago Bears coming in, numerous of them, and one of them that said we could talk about him was John Tate.
That's right.
And he had this right here from probably doing
Throwing the ball.
strengthening or whatever it
Yeah.
was. He had this.
Yeah.
And so did many people have this. And many people downtown have this. This is common. Now I'm getting higher and higher up onto the ribs. So
Kinda
it's a
getting into the,
breathing muscle. This muscle
armpit
helps
there.
you to breathe. So let's feel you breathe. So see, it attaches on all the ribs. So let's feel you breathe. So feel right where my elbow is. Inhale right where my elbow is. Yeah, she's got it now. Muscle's working. There it is. Look at it move. Now I'm going to get higher up, way up there, way high up there. See?
Right into the armpit.
Way up high in the little teeny tiny one.
So you're in the armpit and you're on the rib.
Yes,
right?
and I'm going to show you
Yeah.
a nice picture of this. Ooh, look at my elbows way down.
Ooh, look, it's just resting. It's resting inches down.
Yes, so here we'll take a look at this. Let's see if we can find it right away. See, anterior
Sweet
serratus.
relief.
Here it is, I think. No, that's not it.
A lot of tabs to choose
Oh,
from.
I do.
You know.
Oh, I'll have to put my glasses
This
on.
is the serratus anterior.
Okay, so
But we were looking for the pain pattern, right?
yeah,
We had
I
trouble
guess so. But
finding
here's the. I wanted the pretty picture. Okay, so we're in the subscapularis. See, we got.
it. Let's find our serratus anterior.
Okay, so I'll just look it up in the front. Okay, just 1 second.
Okay. How's it feeling, Stephanie, with the increased range of motion?
It feels good. It feels more like myself.
And how you doing, Camille?
I'm doing good. I'm switching to the other side.
Switching to the other side. So sometimes we use some tennis balls and smaller balls, but in this case, with a big muscle like that, just like Sharon was using her elbow, it's nice to use a bigger ball like this. And you can always get a little bit more localized if and when you feel the need, but it's doing the job for Camille
It's
over
doing
here.
the job. Oh, yes.
Yeah. What are you doing, Sharon? You
Oh, good.
finding
Here
it?
you go. So here I was way up high. So here I was right at, see this little teeny muscle right there? So there's 9 of these. So it was started here, here, here. And I came all along and then went way high up there. You can see here how, this attaches onto the medial border of the scapula. So I was prying the scapula off of the ribs. And you see, if it's just causing it's one pain, you'll just feel it there. As it gets a little worse, you feel it like that, and as it gets worse, you feel it all the way down this way into the hand and into the forearm.
So it like radiates out. Pattern.
And can cause some very achy elbow pain. Okay, and look at, oh my gosh, look at this range of motion here. Okay, so now we're doing better. So we're down to like 6 inches. Oh, I went the wrong way. Sorry. 7 inches. Okay.
7 inches.
Okay, so that's good. So another muscle we want to treat is the pec. Okay, so we're going to treat the pec, and it attaches here. Okay, so we're going to feel it right here attaching into the clavicle, and then we're going to we'll show a nice picture of that.
Yeah.
So nice picture of our pecs.
Now we're going to look at the pec major over here.
Oh yeah, go ahead.
Yeah. So here's our pectoralis major pain pattern. You can see where that attaches under the clavicle there. And we're going to be targeting that finger pain that you see.
It's incredible the kind of finger pain it causes, isn't it? So here I'm right onto the pec. So the way I'm treating it is here I was going right to where it attaches onto the collarbone, onto the clavicle, and I'm going to press on it while I'm increasing the range of motion.
You're kind of holding her elbow in place.
That's right.
Almost like pushing up against the pressure of your fingers.
And you could also use the elbow like this and treat it that way.
Yeah.
And I'm treating kind of broad. And this is a very thin material. It's very easy to work through. And very easy to work through.
It's definitely new.
Yeah. Okay, so we're really coming down here. But usually when you measure, you're trying to get the person to be more at a right angle. So often they start to slip backwards.
Yeah. Make sure there's no cheating going on.
No cheating. No cheating. Yeah. Can't have any cheating.
And Camille is using the ball still.
That's
So
right.
here
Treat that pec
we're
area.
going to be looking at the pec over here. Other parts of the pec.
How's the pec
I'm going to
doing?
shorten it all the way. And let's lengthen it. Now let's take a look at the pec minor. Okay.
Not too much trouble with the pec then so far?
We got a lot of the taut, so the taut bands feel pretty
you felt
good.
Some?
I found some. We treated them.
I didn't hear too many yelps.
She wasn't
That's
complaining
good.
too much.
That's good.
That's better. She's better. And also remember when she was laying down, and we looked. She was only like 1 inch from the table.
That's
there.
right. She had a pretty good
It wasn't too bad. Yeah. She was now with pec minor.
Minor.
Okay, let's look at pec minor. Okay, so we're going to take a look at a nice anatomy picture here, pec minor.
Pectoralis minor. Here's one shot. Yeah, Leslie was asking the rebroadcasts. They are on YouTube. We have a couple of exceptions to that we're trying to work on with some technical difficulties, but aside from that, all of the Bodyworkers Mastercourse is on YouTube under National Self-Care Alliance.
That's right. We'd love you to look at it. It's wonderful. Okay, so you see here it's attaching onto ribs 3, 4, and 5, and then onto the coracoid process of the scapula there. Yeah. So we're going to take a look at that.
Closer picture there. Pec minor.
So we'll take a look at that.
Let's take a look.
So here we got here's rib 1, rib 2, rib 3. So we get right on rib 3. She says yes.
Yes, that one, yep.
Yeah, so here, ooh, I can feel it. So here I'm going to just take it a little bit, and I'm going to stretch it. And remember, this one could actually compress the brachial plexus and can cause particularly numbness in the entire forearm. So it could really be causing trouble. So this would be a way to have thoracic outlet syndrome, as if you had pec minor compression of the brachial plexus. Oh, but we didn't do one test. Oh,
What's that?
I wonder. I must have just. Oh, I saw it there, but I didn't. We didn't do it.
You want to do it?
I'll do it. It's not on that. It's not on that list, I guess. So anyway.
And you're treating your
So-
pec minor over here.
Yes.
Pretty similar technique. You just kind of have to.
I'm gonna check.
Put
Move
my
your arm up,
arm
yeah.
in this position instead.
And you find that ball is still pretty
This is-
effective for you?
Ball is fantastic.
Yeah, fantastic ball.
Well, isn't it?
Fantastic.
Don't we love that ball? We
Love
love
the
it. We love it.
balls.
We love it. That's like an essential ball.
We're having
Okay.
a ball.
So what you want to do is.
You have all the balls.
So we want to feel her radial pulse. So I'm feeling the radial pulse. I can feel like, oh, it's pulsing good. Okay.
Oh, so we're testing for nerve compression.
That's right.
Oh,
Okay.
that's
So we want to see not only just nerve but also blood supply. So we're looking. Do we have blood supply compression?
Oh, right.
Okay.
Okay, yeah.
So I'm feeling the blood,
Nice.
the radial pressure here, so I can feel it pulsing good. But does it pulse good when you put your arm like this?
Oh, so that's
the test.
Lift the
Yeah. So then
the
you
watch
now,
to the ear test.
and then back.
Yeah, and then
Yes.
back.
Now we see. Does she still have a pulse? Not as much.
It's a little
Okay.
weaker.
It's almost nothing. Okay.
Wow.
So what
That's
we
an
want to
interesting
do
one.
is keep treating the pec minor till we have a radial pulse in that position.
Yeah.
Okay, so that's a really good test, okay, to
Yeah.
know whether the pec minor is causing trouble, okay? Got it?
Yes.
We don't want our blood supply constricted.
No, we don't.
No.
We really don't.
Or our nerves, for that matter.
No, we don't want any of that. No. So this is a good indicator.
Hmm.
If the nerve is, if the blood supply is being compressed on, then you know the nerve is being pressed on too.
Hmm. Yeah, that's a good one. That's why it's so important to move around, move the body passively while
So,
you're treating it,
that's
rather than
so
just in one
important.
position.
Mm-hmm.
That one position only tells you one side of the story.
And remember that one underlying perpetuating factor in hand and arm pain and pain throughout the whole body is lack of movement of your body.
Right.
So we want to move everything. You can't be like not moving things.
And that can be at your own level. It has to just
It
be
just has-
moving,
It just has to be moving. It doesn't have to be hard work.
which inherently allows blood supply
That's
to
right.
come into the different muscles that are being used when you move.
Okay, I'm going to check the blood supply again. So I'm just going to feel the radial pulse
Give
in
it
this
a test.
position. So this is called the Wright's maneuver, Dr. Wright. Okay, feel it? Okay, let's see if we did good. Okay. Yeah.
Yeah?
I'm getting a little bit of blood supply. Let me hear it one
Still a
more
little
time.
constricted, or?
Yeah, a little bit still, yeah. So we still want to do a little bit more until we got it really, really good. Okay, good.
Okay. I don't have a pulse. Am I still here? No pulse whatsoever.
No
Camille
pulse.
is a ghost. The
No
ghost
pulse.
among us.
Uh-oh.
Alright, well that might mean she has some constriction even in that position.
Well, are you
Could
good
be a
at
few
you good
things.
at doing your own pulse?
I haven't done it since the last class
But-
that
but-
we did this in. That was
Yeah.
quite a while ago.
All right, let me check you
Yes.
out.
Let's
Here
have Sharon
somewhere.
check you. She'll help you.
Okay.
No
Okay.
pulse.
No pulse.
No pulse.
Let's just feel it for a second. I feel it. Good.
Okay.
Go. Feel it. Feel it. It's a little light.
Yeah, I was pressing
Okay.
too hard probably.
Yeah. Oh, that was it.
That might have
Yeah,
been.
that was it. Yeah. I even feel it there.
You're doing pretty good.
Yeah, but I didn't take it further back.
It is helpful to
Okay,
have
so
someone
what's
do
the-
that test for you, right? Because
Oh,
Well, I was just leaning against it
Okay.
so it wouldn't
Yeah.
fall.
Okay, so one more time. So I'm just gonna feel it. And you do have to press light enough that you
Yes,
can
you
feel
have
it.
to press
Right.
lighter. That's it.
There it is. Okay. I feel it very lightly,
Okay.
very lightly. So it could be stronger.
Yes.
So if we can get this to be, so we want to get it a little stronger.
Right. Okay.
So keep treating our pec minor till
Keep
we're-
treating
till-
pec minor.
till we have a good blood supply.
Okay.
keep after that pec minor.
Right? Good range of motion and good blood supply. So we're going to be really great.
They're saying they really like seeing you do the treatment and Camille do the self-care.
Isn't that great, Camille?
It's nice to have a pro over here showing how to use the wall.
That's great.
So you could also, you know, for example, you could also use the back knobber.
Oh yeah,
to
we
treat
did that a few
particularly
times.
that one would be
We did
nice,
do that
right?
a few times, right? Mm-hmm.
So that's a handy tool without a wall.
Mm-hmm.
So still on the pec minor here.
I
huh?
just want to see if I can get it to be a little stronger
It's a
pulse.
little challenge. Just see if we can just
Well, you know.
take care of this because it's intolerable.
Right? Okay, I've got a good pulse.
They agree.
And I got a pulse.
Yay! It's nice.
Yeah.
Nice pulse.
Yeah.
Good.
Okay, so that's good.
We got
So-
after that pec
So we
minor.
just stay with.
We showed it who's
make
boss.
That's right. That's right. And of course, we get a really good range of motion here of the
Look at that range
anterior
of motion.
serratus. Mm-hmm.
Is she still on her total side there? Yeah.
Yeah. So we're doing
Looks
good there.
good.
And so we did
And
look at.
that's pretty much where you want it to be. That's about five inches probably from the tabletop.
Oh yeah, this
And
is
that's-
perfect. Yeah, this is
Yeah,
perfect.
she's passing the test now.
She's passing. She's doing really good. And so we looked at the pec minor here, and of course that can cause ulnar nerve. We want to pass that right side, radial nerve, median nerve, musculoskeletal. You could have all the pairs you can have in the whole.
a lot of nerve compression and
in-
paresthesia.
in the
all
forearm
those
and
areas.
hands. Mm-hmm. So that's so important.
Yeah.
Okay, so I want to look at.
How are you doing, Camille? Should we test Camille again?
This
or?
one, we didn't test me. This one's doing better. This one,
Not so good.
somewhat.
Yeah. Okay, so we're going to look at Latissimus dorsi next here.
Leslie was just asking about that.
Oh,
That
great.
We're just getting to the lat.
Leslie's here all the time. Leslie, where do you live?
Leslie's in Indiana. Not India.
Okay, so you're very close in Indiana.
Yeah.
We're waving south.
We're waving.
We're waving south to you in Indiana.
Now I'll wave to the west.
Yeah. To India.
I'll wave to the west. To my sister.
Okay, so here's our lat, and look at how it attaches over here.
Oh, she's in Naperville now.
That's right, west on Naperville.
Oh, great.
So here it attaches onto the hip, right? And then attaches on all over here onto the sacrum, all through here, and then up here to T.
It's a troublesome one.
And then all the way over here to the arm. So we're going to treat that one, and we want to see if that was pulling her down, because remember the one fingers was a little shorter on one side, so we want to see if it pulls her down. Okay, so we're going to check that, and of course, remember it causes pain down into the little finger side and into the fingers.
Yeah.
Sometimes I find it goes into the middle finger, sometimes too. Okay, so we're going to take a look at it.
Check out that lat. How do you feel after getting your pecs treated?
Feels a lot better.
Yeah.
Okay, so for this, we're going to put it on the stretch, and we're going to put...
This one, you have to do some really interesting positioning.
we do. Excellent point. So
I remember from you positioning me for this one.
this one, see here, it attaches onto the hip, so we're stretching and we're pushing it down, it attaches onto the arm here. So we're bringing the arm up with the hip down, so we're making it longer.
Really exposing and making longer the latissimus dorsi. Yeah, that's that
Okay,
sort of
so we're going to treat this.
side stretch position.
There. So I'm anchoring her, and I'm right on it. You notice this, Stephanie, don't you?
This one has caused me some intense pain.
I'm thinking that this one's pulling you down on the right side. And Stephanie thinks she might have got
because
it
of the
from
shoulder imbalance.
Yes, correct. She might have got that from flying. She just came back from a flight.
Mm.
And flying can be tough on us, right?
Yes. Especially a 5-hour flight.
Oh yeah, from the west. Yeah.
So I'm holding her in the right position, and I've got my elbow, and
Anchoring her with one hand.
I'm really stretching this latissimus dorsi.
Yeah.
I've really got it on the stretch here. So I'm looking for taut bands in here.
So Camille, I think if I were you, I would stretch this leg, the leg that you're on back, so you can expose that a
This
little.
leg?
Yeah,
So just,
so you can kind of imitate that.
oh, yes, I see what she's doing.
Yeah.
Bring this leg.
That's it. You got it, Camille.
Okay.
Well, I'm going to come down to where it attaches onto the sacrum.
Feel pretty intense, Stephanie?
Yes.
Yeah. Big muscle.
Wow.
So I'm just going to attach. Look at this attachment a little bit.
Hmm.
Okay, I'm going to bend your knee. And we're going to take a look at the attachment onto the sacrum right here. Using my thumb.
Oh, Sharon does have thumbs, everybody. She uses them occasionally.
She likes to use the thumbs and knuckles on the attachments.
I do.
I notice.
Okay.
Yeah.
That's because you have to get right to the localized point where it
Mhm.
attaches, right?
Right.
And that can be helpful.
This comes all the way up to T7. Look up here.
Mm-hmm. Skin rolling. a
Oh,
little.
wait a minute. You tell me, where did you had shingles?
I
What
did,
was
but
it?
that's on the left side.
Ah, it was on the left side. Okay. Okay. So we're not bothering the shingle side.
No.
That was a while ago, right?
Yes.
It can happen to anybody, right?
Yes. Any age range now for some reason.
Any age range, yes. Okay.
Well,
Okay. Okay, so we're just about finished here. Okay, so I think we treated all the muscles, didn't we?
did we?
Yes, we did.
All of them? Yeah.
We did. We did it.
Yeah, we did it.
All right. We did it. Okay, let's have you go ahead and sit up.
So I think, as I recall, Latissimus dorsi and Serratus anterior were two of her bigger issues.
Yes, they were.
And
We're going to see
did
if
some nice treatment.
see if she's more symmetrical. Okay, we're going to check it out.
All right.
See if she's more symmetrical.
Let's
Just
see.
Try it. We'll just try it. I'm just going to let you relax there for a minute. And then I lower the table. Then I'll
Kindly lower the table.
I don't have to jump right after. Okay, so let's have you go ahead and stand up. Let's see what we notice now.
Okay.
Okay, let's see how we did.
Let's see.
Okay, so here we go.
Going back and doing our assessment again.
Okay, so here you can see that she's much more even. So here you can see, but maybe we have a
Spines of her
slightly a little bit
scapulae.
to, lower on this side. So
Yeah.
often for that, I'll go
A little
ahead
more.
and I'll have you put your thighs right on the table. Okay, and a lot of times I'll just go ahead and I'll actually feel what's keeping her in that position, and I'll just move
See
her
where
to-
there's resistance.
until I find the spot that's not allowing the move.
Getting intimate. It's like a little dance.
That's it. Then I check it. A lot of times I've just fixed it. Yeah.
They say
So here-
Happy Valentine's Day.
Happy Valentine's Day. Okay, so let's check and see how we did now. Okay, so let's. I do see something else that needs to be treated. Aha, pretty even now. Okay,
A little bit better.
We got very good. But I see a few more things in there that need to be looked at. But at least we got her pretty good now.
Yeah,
Okay,
we've
so we're
made
gonna-
progress.
We're gonna do some range of motion exercise at the end here. We got our music.
Yeah. So I'll give
Okay.
some. We've got a couple more classes, or let's see, what do we have?
Oh yes.
We have how many section?
Okay, let's
This
talk
is the
about
last
it.
one for our arm and elbow pain.
Yeah,
relief
for
program.
arm and elbow.
So now we're moving
Now we're gonna do
into
to
wrist and finger
so
pain
volar
relief.
finger pain. Okay.
Yeah.
So this would be here. So we're gonna do volar finger pain next. Okay.
And then
Mhm.
we'll have
And then-
classes every Tuesday through the 21st in that
That's right.
program.
Look,
and
we
then
have
that'll be the end
golfer's
for now.
elbow on and medial elbow, or how about when your pitcher's elbow?
Yeah.
Pitcher's elbow, golfer's elbow. That's coming up on February 28th.
Yeah. So that'll be the next series of classes through
That's
our
right.
last on the 21st. And then, again, final reminder to get their 2 CEU credits. Just email us at info@myopain.com. Tell us your Periscope handle, tell us your name, tell us your license number, tell us the name of the class you took, and we'll make sure that you were tuned in. And then, yeah, tell folks about it, and I hope you guys tune in again next week at 6. Here we go. Motion.
Copyright 2017.
Sharon and Mareva from Pain Free, who want you to remain free.
Down.
We will assess and you
Behind your ear.
then
In front of
compress
your ear.
and repeat.
Other side. Over your ear.
Will balance your posture from your feet and effectively
Rotate.
treat on the stretch and on contraction, restoring full function to every action. Come to our tower to meet Sharon Sauer. Use the body support system for side lying position and hydraulic lift table. If you are not able to jump
A little more. A little more.
when a trigger point is
There's
there,
always more range of motion.
we'll teach you how to do self-care. This will keep you at your peak. So see you back
Thumb.
again next week.
See you back again next week. Sharon was waving with her wrist there.